Yeah, hi, I'm Will Shaplow, and I'm the chairman of the McSwain Trauma Education Project. I want to welcome everybody here. Please, if you're not muted already, please mute yourself. It's distracting to the presenter, and we're only here for an hour tonight, so we want to make sure that the presenter is able to get all the content out to all of you. We will monitor the chat feature throughout the night, so if you have questions, go ahead and put them up, and we will make sure if it's urgent, we'll make sure that the presenter has it. If it's not urgent, we will make sure that it comes up at the end of the presentation. Feel free to ask questions uh, throughout, and again, we'll ask for them again at the end. Again, the McSwain Trauma Education Project, if you're not aware, this is to sustain or extend the legacy of Dr. McSwain, who always felt that uh, quality education should be available to providers everywhere. And that access was not available to most providers throughout the country and, for that matter, the world. Uh, Most EMS providers we know never make it to one of the big national conferences and might not have access to the literature and all the things that determine our practice. So the concept or the mission of the McSwain Education Project is to bring national level speakers to the masses, in a sense, so that everybody that wants to can hear the latest science, the latest practice, the latest standards of practice, and the discussions that take place at a national level to help determine where we're going and why we're going there. So tonight's speaker contributes to that greatly. Dr. Patrick Greiffenstein is a trauma surgeon and trauma ICU director at the Norman E. McSwain Spirit of Charity Trauma Center, New Orleans. He's a professor of surgery at LSU Health Science Center, where he also serves as a surgical critical care fellowship program director. His research interests include hemorrhagic shock, chest wall injury, and surgical history. He's been involved with training U.S. Coast Guard aviation survival technicians and Navy special warfare tactical medics, and is currently conducting research examining the aspects of CPR in severe hemorrhagic shock. And to be good stewards of your time, with no further ado, Dr. Greiffenstein.
Thank you all. It's truly an honor to be here and to present this to you all. It's work that I'm really, very proud of, very passionate about, and holding with the spirit of Norm McSwain, who's a mentor to me. I had a chance to work with him as a junior faculty for a couple of years before he passed. Somebody who I deeply admire and carry with me still in my heart and in my practice. And one of the things that he, as you all know, one of the things he always did was sort of challenge the convention and never sat on, well, this is the way things have always been done. He was always one to think, how can we do things better? How can we improve? Very open-minded and definitely a pioneer in the field. And the trauma PEA is just one of those things that's always stymied me and those of you who've been in those case scenarios, you know what I'm talking about. There's hardly anything more frustrating, exhilarating, and devastating than dealing with somebody who's in active traumatic cardiac arrest. These are my disclosures. They're not relevant except for the funding for intramural research that we did that I'm going to talk to you a little bit about here. This is a case of a patient in New Orleans EMS, a colleague of mine, a former Navy SEAL, medic who was involved in the pre-hospital blood program, was riding along with the ambulance crew in New Orleans EMS a few years ago. And they got called out to this case. This scene, a young man shot in the groin, through and through, gunshot wound to the groin in extremis. On the scene, your typical scene, lots of blood, heart rate in the hundreds. Patient was acutely unstable, deteriorating, clearly not doing well. My friend who's just recently graduated Tulane Medical School, was familiar with the tourniquet and along with the paramedics they were all able to apply it to the site. But the key thing was that while they're packaging this patient up, the patient loses vital signs. Now, the paramedics did what all paramedics trained to do, start CPR, right? No pulses, you got to start CPR. Well, my buddy had done 3 tours in Afghanistan, and was a little bit baffled at what they were doing, because they don't do that in the field. They don't do CPR in traumatic arrest in the field in the military. Instead, he said, "Look, guys, why don't we just get blood into him? Let's get access, let's get blood, and let's get hemostasis." And so there was a little bit of a back and forth. The paramedics went and put the Lucas on the machine on the patient, started doing that, while my friend and his colleague were getting lines and applying the junctional tourniquet. As they were doing that, the CPR machine started. They got a unit of blood into this kid, and all of a sudden, the kid starts waking up and flailing, and throwing haymakers. And it was obvious that the patient had never really gone down completely. We just had lost pulses. And like I said, in T-triple-C, the focus in patient who is not suffering from a cardiac event, the focus is always going to be on everything else, and CPR is going to be a second thought. So why is this disconnect? Why is there a disconnect between military practice and civilian EMS? And more importantly, I want to present to you that there is a real disconnect between the science of resuscitation, and what we do in ATLS and PHTLS. That the science of resuscitation doesn't really conform with what we're actually doing. And then lastly, I'm going to touch on this a little bit, is the goals of care don't really align with what we're doing and why we're doing it. And not completely misaligned, but there is a lack of understanding of what's going to happen downstream when we're doing things like, major resuscitation in the field and somebody who's lost pulses. So I do think it is time to rethink the whole thing, because a lot has changed in the last couple of decades. The Pulseless trauma victim is a conundrum. It's a very, very challenging situation. You just don't have the time to do much of anything other than act quickly, decisively, with very, very limited information. All comers survival is less than 10%. That's quite generous. Most studies hovering around 4% all comer survival. And then for patients who actually have functional recovery, that is, patients who actually wake up and leave the hospital with more or less mental competence, that's less than 3%, and it's actually closer to 1% overall. And that's pretty abysmal when you think about outcomes for any other intervention that we do in medicine, period. So we really need to ask ourselves, are we doing all the right things? And are all the things that we're doing the things that we ought to be doing? And a good place to start is to ask ourselves, who are the survivors? Let's find out who is making it from these trauma PEAs. And it's a very exclusive club. A couple of decades ago, it was essentially nil. If you needed CPR in the field, you were not going to survive, period. A few years later, survival outcomes had improved a little bit. It's about 1% survival of pulseless patients in the field. And that only improved very, very slightly in the last few decades. Norm McSwain did a retrospective study out of Charity Hospital before he passed. I think it was published in 2015, where we looked at 193 traumatic cardiac arrests, and there were only 5 survivors. And by the way, only people who had signs of life, so vital signs, EKG rhythm on the rhythm strip, even though they were pulseless, those folks survived. The only person who survived from asystole was a gentleman who was profoundly hypothermic. So the rare cold evening in Louisiana, this guy made it, and we know that that's a very different situation clinically. This is a really interesting study because it's sort of an outlier in several ways. This was a study out of the military. This is a study out of Helmand Province, and it followed patients prospectively who had suffered essentially traumatic cardiac arrest. Now, I'm going to refer to traumatic cardiac arrest when I don't believe that that's what we're talking about. We refer to traumatic cardiac arrest as somebody who has pulses, but as I'm going to show you in a little bit, I don't believe that it's truly arrest in the sense of the cardiac activity has ceased to happen. I just believe that it's hypovolemia to an extent where we no longer feel a pulse. But for the sake of the presentation, I'm going to refer to traumatic cardiac arrest as all cases of pulseless trauma. Um, so these patients were followed for 2 years in Helmand Province. 54 patients underwent cardiac arrest, of which there were 4 survivors. Now that's 8%. That's quite a bit higher than the rest of the population. It was interesting in itself. Now remember, these are very healthy young men, right? So the healthiest, fittest, young men in the country. And so that definitely skews things. But there are a couple of other elements that are interesting here as well. This is what's really key to me. This was exciting to me that all 4 survivors are neurologically intact. And that's truly unique among the literature, patients who survived traumatic cardiac arrest. Now, all of the survivors suffered massive traumatic exsanguination. So this excludes traumatic brain injuries and other types of injuries, burns, etc. So these are all massive exsanguination. And 24 of them got an echocardiogram. 6 of those patients with echocardiogram had organized cardiac activity, of which they were all the survivors were in that cohort. So only people who survived were the ones who had cardiac activity on echocardiogram, even though they were pulseless. 2 of them survived the discharge. And none of the patients who were in asystole survived, and that's really key. Elizabeth Curitin out of Denver did this study, which is really remarkable. They took 162 pulseless patients and they looked at evidence of cardiac activity, either by EKG or by ultrasound or both. And what they found, once again, is that only patients who had evidence of cardiac activity, despite being pulseless, survived. None of the patients who were in asystole who had no cardiac activity survived. Similarly, the study out of California, Kenji Inaba, looked at resuscitative thoracotomies, 223 of them. And again, only the patients who had positive fast exams, rather positive cardiac activity on cardiac sonography, only the patients were survived. And by the way, this is a test with essentially 100% sensitivity and 100% predictive value, negative predictive value. That is, if you don't have a positive cardiac activity, you aren't going to make it. And similar to other studies, only about 1% of the total population survived neurologically intact. And in this study, we're looked at the futility of close compressions after traumatic multi-institutional injury, and it's not a great study, except for the fact that it really reiterates the fact that this is a survival cohort of the young. Folks who are in the 70s and up, if they suffer cardiac arrest from traumatic injury, their chances of survival are extremely rare, if not nil. Now, when we're talking about pulseless electrical activity, we have different ideas of what that is. Now, PEA, according to the cardiologist who first coined the term, looks like this, right? And you've seen it, right? This is a heart that is quote unquote beating, that has cardiac activity of some sort, has electrical depolarization, but really is not effectively beating, right? So the heart is filled, it is twitching, but it's really not moving blood. That is what the cardiologist rather, were referring to when they say PEA. What we've done in trauma over the last few years, we started using an ultrasound to examine our trauma victims. And naturally, we started looking at trauma victims who had no pulse. And we found is that patients who came in a PEA, quote unquote, didn't look like that. They looked a little different. They looked like this guy. This is a patient of ours, 34-year-old gunshot wound to the abdomen, who was taken emergently to the operating room. He underwent a splenectomy, mesenteric ligation, and he had fairly rapid hemostasis, but apparently we weren't keeping up with the resuscitation quite enough. And while we're in the operating room, we're working on the guy, and the anesthesiologist says, "We're waiting on blood, and I don't feel a pulse anymore." Right? So I've lost cardiac pulse. So you need to start doing CPR. Now I had just been up in his near his diaphragm, and I could see his heart beating. So I knew his heart was beating, and I didn't think he needed mechanical help. I think he didn't need mechanical assistance. He needed blood. And so I took the ultrasound probe, which just happened to be in the field because I had placed a line in earlier, and I put it up against his heart, and this is what it looked like. So this is a subdiaphragmatic view of the heart. Oh, hold on. Oh, sorry about that. Let me start again. Let me start from over here. There we go. So that heart is doing everything it possibly can, as well as it can, and there's nothing externally that I can do to improve that function. That ejection fraction, that's the right heart, right there, and you see it's relatively flat. And the left heart is completely empty. With every contraction, it's evacuating greater than 80, 90%, almost 100% of its total volume. So ejection fraction is almost 100%. I'm not going to improve on that cardiac output with squeezing on the heart externally. So we didn't do that. So rather, we ignored the anesthesiologist, and we instead suggested he flood him with blood, which they did. Patient got his pulses back and made it out okay. So the concept is patients who survive are those who never lose cardiac activity. The reason they don't have a pulse is because they just lack the amount of blood required to generate that pressure to feel a pulse in the periphery in the carotids or the femoral arteries, right? So if that is the case, and a pulseless trauma victim who has cardiac activity, that patient has hope for survival. That's the patient who has some possibility that they're going to survive, and they're going to potentially survive with some neurologic recovery. And if we believe that trauma and PEA is usually from massive exsanguination and somebody who's got a beating heart, then and we assume that 100% mortality is inevitable in asystole, then why are we doing CPR and pulseless trauma, right? Patients who have asystole are essentially dead, and patients who don't have asystole have a beating heart, and they don't need mechanical compression, right? And that's the premise. And the reason we're doing CPR is because BLS and ACLS say that pulselessness for a trauma victim is exactly the same as it is for anyone else. That there is no difference between a 25-year-old who drives a motorcycle into an embankment at 100 miles an hour is essentially the exact same patient as an obese elderly woman who falls down at the buffet line and has an MI, right? And we know they're not the same patient. Physiologically, cardiologically, they're not the same patient. And those are the AHA guidelines from 2010, which have not changed fundamentally. The question isn't just, is it helpful? The question is it harmful? Could we be impairing survival by doing CPR? And that was a big question that I had. Now, is it counterproductive? Many of you have been there. You've been in the back of the truck, you've been on the scene. And I ask you, because I've seen it in the emergency room, but that's only a snapshot of the recovery piece. Do you forego doing other things? If there's two providers on the scene and you're doing CPR, who's getting hemostasis? Who's starting the lines? Who's doing all the other essential life-saving measures that are necessary for maintaining life, right? CPR hinders procedures. When the patient rolls into the emergency room, this is one of the main reasons I really was interested in changing this. CPR is underway. People are in the way. You can't get online. You can't get easy access to the airway if the chest is rocking violently because people are pounding on it. So it just gets in the way and it delays, and there's a potential risk for complications. And it's physically taxing. People are doing CPR and it's exhausting. A minute or two of CPR, and then you're expected to turn around and place an IV line in somebody's very, very small compressed antecubital vein. That's challenging. So we really need to know if this is worth doing. What does the science say? Not much. There really isn't much. When I went to look for evidence that CPR was at all helpful in this situation, I found very little science on the subject. This is the earliest study. Took 3 baboons and they exsanguinated them, and they did hemodynamic studies. And what they found was that There was a slight augmentation in systolic blood pressure, a decrease in diastolic blood pressure, and no effect on mean arterial pressure. So doing CPR does not actually affect the mean arterial pressure. Increase in systolic, decrease in diastolic, which begs the question, what happens with coronary perfusion? Because as you know, it is during diastole that the coronary vessels get perfused. So if we're impairing diastole, diastolic filling of the coronaries, potentially we're causing more damage to the to the myocardium doing CPR in these situations. This was shown again by Jeff Coach out of Tennessee. They looked at dogs, 18 dogs, did a fixed pressure examination. They had three groups, IV fluids, CPR only, and then CPR plus IV. And I'm just going to briefly mention that the light gray line is the CPR only group. And as you can see, essentially did nothing to improve the mean arterial pressure, improve the base excess, or the ejection fraction in these animals. CPR alone conveys no improvement in hemodynamics, and really it was the fluids that did the work. We did our own set of studies using pigs. So we did a porcine model of hemorrhagic shock. We took 14 pigs. We did hemorrhagic shock. It was fixed pressure, less than 30 millimeters of mercury. And we did two groups. One group we did CPR during this period, and the other group we didn't do anything. And then we resuscitated them with shed blood, and then we allowed them to recover for 60 minutes. And it was really interesting. The animals were all anesthetized. I was interested in not so much the hemodynamic aspect, but in the downstream effects. So what does CPR during hemorrhagic shock do to perfusion and oxygenation? So I did transcutaneous oxygen sensors on the skin, and I did transcerebral oxygen sensors. So I drilled a hole in their skull, and we put a little oxygen probe through the skull into the brain parenchyma to measure oxygen. This is our model. We used an auto-pulse device, which is what's validated in this model. You have the brain probe you see right here on the top of the pig's skull, and we did CPR. And by the way, if you own a large animal, this is how you do CPR. You do it on the animal's side. You put your hands right behind their elbow. That's the ideal source for doing CPR in large quadrupeds. Oh, there we go. So the results were interesting. Again, just like the other studies, we found no improvement in mean arterial pressure between the two groups. Systolic was improved, diastolic was less in the CPR group. We did find a difference in the transcutaneous oxygenation in animals during CPR. So in the animals who received CPR, especially during recovery, there was a lower amount of oxygen going into the periphery. So the CPR group is in the red line, the blue line is the no CPR group, and as you can see, during that 10-minute shock period, the CPR group did a little bit worse in terms of the oxygenation, and that actually diverged even further during recovery. The cerebral oxygenation didn't quite reach statistical significance, but it did in the transcutaneous oxygenation, indicating that CPR may actually impair perfusion. It doesn't do anything for mean arterial pressure, but for some reason, adding that effect of pumping on the heart may actually cause impairment of flow downstream. So that was interesting. Other countries have started to pay attention to this. The latest Royal College of Emergency Physicians Best Practice Guidelines, published in 2019, suggest that interventions that are considered standard for medical cardiac arrest, in other words, an MI, could potentially be avoided in trauma. In other words, CPR, you don't need to do it in a trauma patient if you don't feel like it's indicated. Instead, they put the focus on the POCUS. So point of care ultrasound, they said, was essential in determining the need for cardiac compression and other interventions in the setting of cardiac arrest, and particularly in the setting of trauma. And that's really essential. The European Resuscitation Guidelines a few years later came out with cardiac arrest in special circumstances and said the same thing. Traumatic cardiac arrest is different from cardiac arrest due to medical causes. Use ultrasound to identify the underlying cause, treat the reversible causes, focus on other things, don't do CPR unless it's truly indicated, and really should be focusing on hemorrhage control, airway, IV access, resuscitation, and don't pump an empty heart. I love that. Case number three is a great example of why it's essential to use ultrasound during our resuscitation. This was a 30-year-old male found out in New Orleans East, side of the road. Who knows how long he'd been down? Clearly been dumped there. He had 2 gunshot wounds to the right hip, and he was pulseless. He was hypothermic. He'd been there for a long time. It's one of the colder nights of the year. And EMS showed up. He had bone reactive pupils, no signs of life, except that he was bradycardic at the sinus rhythm of 35. So on EKG, he had a sinus rhythm, so they went ahead and worked it. And this is kind of what it looked like. Gunshot wound to the upper thigh. Relatively easy to get hemostasis. We get him in the trauma bay, and we pause CPR, and he's got a PEA of 30 to 40 beats per minute. On echo, he's got very, very low volume, but he's got weak contraction. So heart is actually working and it's organized. And he's very, very hypothermic. So we just said, we have hemostasis. Let's resuscitate him and see what happens. So we got access. We pumped him full of blood, and we started rewarming him. Within 10 minutes, he has a faint pulse. Echo improved contraction. Left ventricular volume is restored, and now he's got a heart rate of 50 to 60, systolic blood pressure 70, and we were able to take him to the operating room. Ongoing volume resuscitation this whole time. We explored his leg. We did it with a Melmont. We explored his groin, revealed soft tissue destruction, large amount of bleeding from really unnamed vessels, no major arterial bleeding, and branches of the femoral vein were ligated. Overall, the patient was profoundly coagulopathic, so we really had a lot to work on metabolically, but there wasn't anything to work on surgically. In other words, we had hemostasis. Now, we paused mass transfusion protocol after about 12 units, 10 units of FFP, where things are looking pretty good. Systolic blood pressure in the 1 teens, and then it's up in the 130s, and it's in 150s. So things were looking pretty good. We're pretty happy. We're starting to package him up. We're starting to close the wound, and it starts to drop again. 100, 90, 80, and the anesthesiologist yells, "Let's restart MTP." And I said, "Hang on a second, because I've been looking at this guy, and I don't see where the blood is going." So he went from 150 to 80 in a span of about 20 minutes, and no more blood had been lost. So what is happening here? We looked at his heart, and it looked like this. No contraction, massively dilated right ventricle, massively dilated left ventricle. The patient was just volume overloaded. So very high ventricular volume, very poor contraction, and he had even spontaneous echo contrast, which is when there's such low flow that the blood aggregates within the cavity, and you can actually see it looks a little bit like snowflakes in a snow globe. So this is volume overload. I said, stop the MTP. Don't give him any more blood. Just put pressors on him, and let's help his heart contract. And that's what happened. And here's the thing: is that if you're doing massive resuscitation, you don't know which side of the Starling curve you're on. You could very easily go from, and you're dumping blood into somebody at a liter a minute. You don't know at what point you reach that peak, and next thing you know, one more liter and you're over. And now you're actually causing cardiac dysfunction from volume overload, and you just don't know when that happens. So it really is essential for us to monitor the cardiac activity, not just pre-hospital, not just in the trauma bay, but also during resuscitation to make sure that we're doing the right thing. We really need a good look at the heart to know what we're doing in these trauma patients. Point-of-care ultrasound is essential. Right. Last case I'm going to talk to you about, 27-year-old kid, stabbed in the brachial artery by his girlfriend. He's bleeding out on the couch for 20 minutes before cops arrive. They show up to put a tourniquet on him, and he slumps over and he's lost pulses. The cops had the tourniquet on his arm, and they start doing CPR. Now, they are 45 minutes away in northern Slidell. So they're pretty far away, and they're quite a ways away from the trauma center. But they have hemostasis, young man, and they decide we're going to put him in the truck and go. Now, current guidelines do exist, and they say do not do CPR if the patient has lost pulses from trauma and you have more than 15-minute travel time. Those are the guidelines, and Dr. McSwain was one of the co-authors on these guidelines a few years ago. And that's been the convention. And fortunately for this young man, the first responders ignored convention and brought him in. So he comes into the trauma bay. His on EKG, he's got a systolic, he's got a sinus tachycardia in the 160s. He's hyperdynamic on echo, but he still doesn't have pulses. So rather than restarting CPR, we said, let's just focus on getting blood back into this kid. And we did. We just focused on lines, got an airway, started resuscitation. 12 minutes later, he's got ROSC. And he was actually 28, not day 8. It took a little longer. Hospital day 28, he leaves the hospital for rehab unit with a GCS of 15. He had a little spasticity, but beyond that, he was neurologically intact and he did really, really well. The idea of 15 minutes is really based on um, a surrogate for cardiac viability. And that's all we've had so far, right? So studies examining the 15-minute cutoff, for example, showed 13 to 14 survivors would not have been transported following the strict guidelines. So in one study, almost all of the survivors were outside of that window, right? In the military study in Helmand, one survivor who had a transport time of greater than 20 minutes. Again, he should have been left to die. And this is a guy who survived neurologically intact. So the idea that we have to stop CPR or that we have to resuscitate anybody who has more than 15 minutes of CPR is based on very limited information and is not an accurate reflection of what's actually happening. So I do think it's time to change what we're thinking about in terms of viability of a patient. And I don't know that it's time to definitive treatment should be the sole determinant of whether or not we should do CPR or other interventions. So what makes for successful recovery? We really don't know. It's extremely anemic. The military patient experience, our own patient suggests that patients who survive are young. That the cause of pulselessness is strict exsanguination. So cardiac compression, et cetera, is a little bit different. Cardiac contusion, rather, is a little bit different. Early hemostasis is key, and patients never reach asystole. And then in the military, and we started doing that recently in university in New Orleans, but in the military, they have a pretty robust pre-hospital blood transfusion program. And so that, I think, is another key component of survival. So if we're not going to do CPR, what are we going to do? I think the key is we need to redefine the condition. So we need a new approach, right? This is not cardiology. We're not defining our patients by their condition. We're defining it by conditions that were described and interventions were designed around cardiac dysfunction. Completely different animal, right? Trauma arrest, we should be talking about pulseless trauma victims, not traumatic cardiac arrest, because we don't know that they've arrested. Arrest means cessation of motion. And I'm telling you, and you've seen this before, these patients don't have an arrested heart. That heart is still beating. So we should be talking about patients who are pulseless, so pulseless trauma victim, and it's either hypovolemia, pericardial tamponade, direct cardiac injury like a contusion, or the patient's in asystole, in which case it potentially is a lethal condition, right? Pulseless electrical activity should be a different thing altogether. It shouldn't be talking about PEA and trauma, right? It should be pulseless hypovolemia until proven otherwise. Traumatic PEA really should be out of the lexicon, in my opinion. It's a completely different entity from the AHA classification of PEA. So my proposal is review the current guidelines for resuscitation and pulseless trauma. We really need to introduce point-of-care ultrasound as an essential component of our algorithm. Primary assessment in ATLS needs to include POCUS in the field, throughout resuscitation, in the trauma bay. We need to reconsider the role of CPR in traumatic cardiac arrest. There are some times when you need to do it. I'm not saying we should throw away CPR altogether, but we're using it on everybody, and I don't think it's necessary, and it may be harmful. We need to revise the national database so that we have more granularity about these patients. Right now, it's very little information available for researchers who want to study the broad impact of this disease out there. So we need more granularity. We need to know what the heart rates were, what the EKG rhythms were. We need POCUS information to be included. And we need outcomes. We need better outcomes on functional recovery, because when we're talking about survival, if you look at one study, it might say survival is 5%. and you look at another study that looks exact same population, survival may be 1% or 12%. Survival is defined differently by different authors. I've seen authors who define survival as survival to organ donation. That's not survival. Forgive me, but that's not survival, right? So we need to be very clear and very careful about how we design and how we define survival. And we need to understand what our functional outcomes truly are and why we're doing what we're doing. How many of us would expend the amount of energy and effort that it takes to do massive resuscitation on these folks, knowing that there's a 1% possibility that this patient's going to wake up, right? So we just need to be more informed about what's happening and what we're doing. And we need to train and equip EMS personnel with portable POCUS. It's there, the technology is available, and we can do this. Is it feasible? 100%. This is an anesthesiologist named John Mitchell out of, now he's in Detroit, and he teaches a course exclusively for Navy SEALs, Navy SEAL medics. And this is a Navy SEAL medic doing a fast exam. And if you could look at your clock, at your watch and see how long it takes for him to do a perfect fast exam, to get perfect windows in this simulated patient. Right? Now, left upper quadrant, he's got a good view there. Actually, he's doing a cardiac exam first. 4 windows. Right? Subxiphoid view. Perfect pictures. Right? He's able to assess quality and quantify, and then do a full fast exam. Right upper quadrant view, left upper quadrant view, etc. Okay. About 30 seconds. Okay. And this is a lay person without any prior medical training whatsoever after a 4-day course. 4 days. 4 days with Mitchell, and this is all of the stuff that they do. And at the end of which, and they've got, volumetric assessment and ergonomics and all this kind of crazy stuff. And at the end of the day, they compare them to trained cardiologists as the gold standard. And they find that the Navy SEALs match the cardiologists at the end of the day almost as good as the gold standard. So almost 4 points out of 4.5 compared to trained cardiologists. So it's totally feasible. It's entirely within the scope of practice of a paramedic or EMS provider, and it's entirely within our grasp to do. New Orleans EMS has started doing POCUS since 2024. This information is very outdated. This is actually much higher now, and they've done some remarkable cases and at least a couple of dozen cases, the point of care ultrasound actually changed the algorithm for the EMS providers in what they were doing. Most of these have been non-trauma cardiac events, but it has impacted how the providers provided medical intervention. Those of you who are English lit fans, if I were to coin a term for this, or if I were to have a meme for this, I would call it more sound, less fury. We need more ultrasound and less just furious flailing around a patient without much sense. We need to assess cardiac function so that we have goal-directed intervention. We need to avoid further harm, and we need to make sure we're good stewards of the resources we have. Do we need to transport and do we need to resuscitate every single patient who has pulses, who's pulseless in the field from a traumatic cardiac arrest? I think we could do better at discerning who we should and should not intervene on. So I want to thank all of my colleagues, all of my collaborators in this project, and I want to thank all of you for allowing me the time to talk about this, and I'll take any questions.
Doctor, thanks. It was a great talk. We did get we have a question or two, and you guys post up any questions you might have, and we'll continue the conversation. One of the questions that came up, Doc, is what do you think about Reboa as far as its
Absolutely. It goes in line with focusing on resuscitation and hemostasis. So we need to make sure we've stopped the leak and we fill the tank. That's the source of the entire problem. So that's what we need to focus on. In fact, I tell you that um, in the cases where we're able to get ahead of the resuscitation, the minute you start doing a blood resuscitation on these folks and you have hemostasis, they wake up. So they go from a GCS of 7, about to be intubated, to awake. And I've had this conversation with several of my my ED colleagues who really want to intubate these folks in the trauma bay because they look terrible. And I don't let them. I just say, look, we got a Reboa up. We're gonna pump them full of blood, and we're gonna bring them to the operating room. And they don't know it, but in the elevator, by the time we're in the elevator, usually these folks start to wake up. So if you can provide hemostasis and get the resuscitation in, you improve perfusion, everything changes. The game is a complete game changer. We are one of the few Reboa training centers, Reboa centers of excellence in the country. So I think it's a great tool.
Thank you. I have another question. First, a lot of thank yous coming in as people are signing off, and really appreciated your presentation. Another one is they're concerned particularly like rural applications, and it's like maybe one of the places where something like these physician extending kind of views of what's happening with the patient would have the most value, but the difficulty of the training levels to get the folks up. Do you see an issue there?
Um, I think it's a question of resources. Right now, we haven't done the financial analysis in our own hospital, but other hospitals have done financial analysis of doing CPR and the futility of CPR in some cases. The hospital is spending between 250,000 to $1 million a year, $1 million being, the larger trauma centers in these resuscitation of trauma victims who are not viable. And so if we can improve what we're doing for folks who have no hope for survival, like I said, if you're 75 years old and you suffer a traumatic injury, and even if you have some cardiac activity, the odds of you waking up and leaving the hospital are essentially zero. So I'm not saying I need to make the decision. I'm saying we collectively as a medical profession need to determine, what is really in our best interest. And rather than spending money and resources and efforts and trying to save every single person, let's understand who is truly likely to survive and use those resources instead in equipping our personnel to be able to make that to help us make that determination earlier. So rather than bringing in every trauma PEA that comes in, we'll have better trained paramedics in the field to do that in conjunction with ER physicians and trauma surgeons. Um, we'll be able to make a decision. This patient really is not viable. We shouldn't bring this in. And so I think that the cost effectiveness it just makes much more sense for us to be smarter about how we do this um, and how we use our resources. And for that, we really need to train up our people. It's entirely within our ability to do so.
Thanks. While I queue up some more of the questions, Chris Mattis is asking if you could back up to that slide of POCUS and New Orleans EMS stats. Maybe you'd be able to see that again while we're talking about the next question here.
Yes. That has dramatically improved. I think they're up to like 80 cardiac arrests that they've done focus on, um, and several of them have been found being pseudo PEA, and rather than doing CPR, et cetera, they were able to start pressors and get these patients back. So they've actually had real time effects in what they've done. I can't speak to much more of that in detail. My colleague Dave Rayburn has been spearheading this for New Orleans EMS, and we're hopefully going to have some more updated data this year. We're presenting it in World Expo, EMS World Expo in Indianapolis.
More comments again, thanking you for the presentation. Another one is asking when the last ACS or anybody's national standards for CPR and traumatic arrest were published. Is there a date that you cite?
Um,
2003. Um,
the ATLS, which is the purview of the American College of Surgeons, has never had a stance by itself on CPR for traumatic arrest. That has always been guided by the Resuscitation Council in Europe, and in the US, been the AHA. So they're the ones who are saying we should do CPR on everyone. The latest that I saw pertaining to pre-hospital traumatic cardiac arrest came out in March, and I'm sorry I don't have that slide in this slide deck. I forgot to include it. Came out in March, and they suggest that CPR not be included in the essential life-saving measures in patients with traumatic cardiac arrest. Um, what they're suggesting is focusing on true life-saving measures, in other words, airway oxygenation, hemostasis, and that kind of thing, and that CPR should not be considered until those things have been done, at least. In other words, we're reprioritizing. They're suggesting reprioritizing the interventions to everything other than CPR first in the cases of traumatic, quote unquote, cardiac arrest.
I think,
I invite you to look at it. There's the last NAEMSP American College of Surgeons COT trauma guidelines came out in March of 2025.
and I think Greg Wren's question about can an EMT at an hour from a trauma center make a call like this and stay within protocols? I think you kind of answered that. The idea is not that whether it's not just whether or not to do CPR, but it's what other things should you be doing before you're doing CPR, more or less in these cases.
Agree. Exactly. I think that with point of care ultrasound, that provider will be able to make a better determination of what's needed. Like I said, like my patient, 45 minutes out, he's got a tourniquet and he's got cardiac activity, and we're hoping more and more. Now, I know it's a lot, it's a big ask for rural EMS agencies, but more and more people are putting blood in the trucks. So if you can provide hemostasis and resuscitation, blood resuscitation, that person has a chance to survive if they've got cardiac activity. And the provider I would suggest the provider keep track of the cardiac activity en route during resuscitation and continue to do everything else. And now, if the heart ceases to function, then consider doing CPR. Um, I'm not suggesting we throw away CPR completely. I just think we need to rethink where and how we use it.
There was a question a little bit further back about automated devices for traumatic arrest. So like your Autopulse and your Lucas device.
Um, I don't have a preference. I think that some studies, and I know that there are some people have real strong feelings about the Lucas. There have been some instances of liver injuries and malposition of the piston. I think that Autopulse is um, a little more fail-safe, a little more foolproof. You just slap it on, but it is, having done it on these pigs, it is cumbersome. It's big, bulky. You have to wrestle the strap around. So automated devices definitely take the edge off when you're doing CPR for long periods of time. But again, my point would be it gets in the way and it takes a long time. So if you've got hemorrhaging patient, focus on the hemorrhage, focus on resuscitation, airway, oxygenation, everything else first. And then if you really feel you need to, for whatever reason, wrestle that Lucas on the patient, that's up to you. But I think that too often we get patients in, and I'm not bashing my EMS colleagues. They're wonderful. They do an incredible job. I've never been out in the field with them. I don't know what they're dealing with. But too often we do get patients come in and all they have is a Lucas. They don't have access. They don't have an airway. They don't even sometimes have hemostasis. The junctional tourniquet is available and it's really underused. There've been several cases where that junctional tourniquet could have been used. So they're putting the Lucas on before they do anything else. And I think we could do better.
There's a question here too, and it's actually from Mary McSwain, just in case folks are wondering where she's at. She's at Logan Airport, in Boston, monitoring us from her phone. Um, But she makes a good point that you can spend a few $100s or a few thousand on an ultrasound machine. Is this kind of like you get what you pay for kind of situation?
I think that the technology is improving and it's actually getting cheaper. I purchased an ultrasound, a portable ultrasound, for under 6,000. Now it's not peanuts, but compared to some of the equipment on the trucks, it's significantly higher, significantly better, and a really great return on investment if we can improve, again, patient selection. And in the case of a patient we had about 4 months ago, New Orleans EMS alerted us to a patient who had cardiac tamponade. And we knew exactly what we needed to do. I had the OR prepped and ready to go. The patient rolled in the bed in the bay. We got a chest X-ray to see if he had a pneumothorax, and we rolled straight up. And it really required, and I confirmed it with ultrasound, but I trusted the paramedics. So it can save time, and it can save resources in a very real way. And I think, five to $10,000 for a portable device, is, I think, within reason for a lot of ambulance crews. I think we need to support it as a hospital system too.
And you pointed out there are questions that also looked at the level of person that you're going to provide this training to. You're convinced that even like basics, first responders for that matter,
Oh
uh,
yeah.
might be able to do this.
Like I said, we've got Navy SEALs who are, remarkable young men, but they have zero prior medical training. They come to our training facility with just a few months of classwork, and you put an ultrasound machine in there, and you have good, focused, effective training curriculum. And if they know the anatomy, it is really easy. In fact, new technology, and it's already out there. GE has some, and Butterfly has some technologies out there now that will not only help the provider interpret what they're looking at. So it'll actually label structures, but it'll also tell the provider based on haptics. It will tell the provider how they should move their hand in order to get a better window. So this technology is practically gonna do it itself within the next few years. So it's
It's
entirely
interesting.
within. It's probably gonna even be a moot point. The ultrasound machines are probably gonna be doing this thing themselves. But as far as training a person, we train we have trainees and medical students may be good at books, but they're not always the sharpest people on the planet to teach them things. And even with the slow ones, we can show them how to get cardiac windows. And look, and for this, we're not talking about calculating ejection fraction or cardiac output. We're not talking about trigonometry. This is basic sum. So this is the heart beating or not?
Yeah.
Done. Very, very doable. Very doable.
That's interesting to me because a question I had that I was going to add in at some point was when you're training these guys rapid fire to get out there to use the tool, do they know what they're looking at? But if the tool itself is going to tell you
Yep.
left or right, I'm going to get a better look at this. That could make a difference.
It's there. It's already there.
That's awesome.
And sorry, I saw there's a few people talking about like the rural departments and volunteer departments. I just want to throw out there in the state of Nebraska, the very first department we had using ultrasound was a volunteer department. And a lot of your hospitals and your trauma centers will also put in effort to get departments set up on stuff. If this is something you're looking to implement, you can frequently find partners and find people to kind of help you. Some of the smaller handheld options are, $1,300 to $1,500, and then obviously all the way up. So is very feasible and definitely coming.
There's comments too about organ donation. I know you said that that's not a good reason to try to resuscitate. So some people are concerned about that. And I've seen that before as far as when we're looking at ethics and legalities. Uh, the idea is not to preserve organs for transplantation now, but whether or not the patient itself can survive.
Yes.
That's kind of a sticky wicket, though, isn't it?
No, you're 100% right, and I think that my point in saying that was twofold. Number one, that we need to be clear-eyed about what the real outcomes are. Because when you're the one doing that CPR, you're the one doing that intervention, obviously you're hoping for the best. But we need to, as a whole, we need to sit back and look at what the total outcomes are, and understand, that real survival is extremely rare. And then on the other side, I'm suggesting that when we look at studies, when we examine outcomes in our studies, we pay close attention to what they mean by survival. Because, like, again, in my opinion, survival isn't survival to organ donation. So that's just that is just I'm not saying it's sneaky, but it's a little bit misleading when an author suggests that survival is survival to admission, for example, only for the patients to die in the ICU the next day, or survival to organ donation. That doesn't really convey survival, in my opinion. And so I think we need better definition and better clarity in what the real outcomes are in these cases of traumatic cardiac arrest.
I think that's fair. I think make it a conversation first about what survival is.
Yeah.
And then if people want to say, well, we have to talk about organ donation,
Right.
well, that's another discussion.
Correct. Exactly.
What's the EMS's job in this regard?
Correct.
There's a couple of questions. Raylon Meeks, an old friend of ours, and these presentations has got a question about pediatric populations, but also someone would like to see that Navy SEALs slide again too. So maybe you could do both at the same time. I'm asking you to multitask. Sorry about that.
Yeah. So can you say that again? I'm sorry, I missed that last part.
Wants to see the Navy SEALs slide that you had.
Oh yeah, sorry.
And then about any information you might have about these principles of pediatric populations.
Pediatric population is challenging. The reports suggest that pediatric population children actually have a much lower survival rate than adults. Um, Survival from traumatic cardiac arrest in pediatrics is about 1%, for adults 4%. And the criteria for withholding CPR or terminating CPR are actually a little bit more conservative for pediatrics. And so no signs of life at certain points in time during the contact with EMS is considered, reason to stop right there, not based on time to resuscitation. In other words, 15-minute golden hour, the golden time period to get the patient to the hospital. If the child loses pulses and has no signs of life, regardless of the time spent, guidelines are to cease intervention. So unfortunately for pediatric resuscitation, survival is just much worse. And it is, fortunately, it is much rarer to see it in children. But it is always a challenge because we want to do more for them. We want to give kids especially, every possible chance. And we just have to be thoughtful about what we're doing and what our ultimate outcomes are.
Yep. I guess we're right about the end point here. So if I was going to close with something controversial, this is probably the right moment. But since we're talking about CPR in a broader sense, there's been some discussion lately that we've inflated the value of CPR broadly, that the outcomes don't justify the attention or the time. And I only mention that because one of the things that you said, that it was just a part of your presentation that went by kind of quickly, but I think condition-based response, I think, is so much better than this overall, we've got to go here and fix this. It's like, you're not going to fix it unless you go to why they're there.
Mhm.
Certainly in trauma, that makes sense. But do you think we're going to have to get to a point where that might be broader even to medical situations?
I think so, and I think that I mean, I hate to sound like a broken record, but I think point of care ultrasound is going to be essential in those periods of time when we're doing ongoing resuscitation. I can tell you that in my career, I've been doing this for 12 years now. I I've seen a dramatic change in practice in these acute resuscitations when we've got an ultrasound in the room. And I do think that we're able to use that ultrasound to just be to just have a little more finesse about what interventions we use. And sometimes it's going to be cardiac assist device, sometimes it's going to be CPR, sometimes it's going to be different kinds of pressors. So I think it is gonna change a bit. I don't think CPR should go away or will go away anytime soon, nor should it. But I think we are getting better and better at looking into the physiology directly instead of just speculating about it based on a blood pressure or heart rate.
Well, we've gotten to 9:04, and Doctor, thanks for hanging out and doing it a little longer. Clearly, the comments coming from the audience that continue to come in, thanking you for your presentation, about how important what you're talking about is. And I think that the takeaway point that they're saying is what we just finished with is like condition-based. You have to get to, if you're going to take care of these people, why are they where they're at? And what can you do about that versus um, other types of things that traditionally we might have been doing. So thank you so much for your presentation. I think it was very well received, and people are still hammering here um, in the comments section, thanking you for what you've done. Great job.
Thank you all very much. I really appreciate it. It's been a great honor.
Well, and just so you know, now that you're in, we will probably be bothering you again in the near future, but this was
Happy to do it. Happy to do it. Thank you.
And when I said that Mary asked that question, that was really Grace, who's standing in for Mary, monitoring tonight. But Mary did tap in there, so she's out there watching what's going on. I want to remind everybody, this is the 3rd anniversary of our Trauma Talks. So if it's Thursday night and it's the 3rd Thursday of the week and it's 8 p.m. Central Time, sign on, we're here. We've been doing this for a long time. Essentially, as you saw with Dr. Greiffenstein's presentation tonight, it's essentially a literature review and case study. All this stuff comes out so we can kind of figure out where we're at, where we're going, and what works and what doesn't work. We do all of this based on the feedback that we get from you. So continue to let us know what you think, what you'd like to see, what we're doing right, what we're not doing right. This is all about broadening the way information gets to our EMS providers wherever they can log on. The other thing we do is live conferences. We've done them in Mexico. We've done them in Tennessee. We've done them in Nebraska. We've done them in Connecticut. We're looking at Pennsylvania, New York coming up in the future. We've got Erie, Pennsylvania coming up on the 19th of September. We'll be back in Connecticut in June of next year. And we're in conversations with New York. This is something where Dr. McSwain's wish was that we would actually be able to get these types of conferences into the places where people will never leave home to get out to the major conferences. So if you have a site that you think that we could visit, that we could bring the McSwain Trauma Education Conference to, let us know. If you have a topic you'd like us to address, any of these things, we are adaptive and responsive. Let us know what you're up to. Let us know what you think. And we would love to be able to do that for you. And keep in mind that we are a nonprofit. All this stuff is paid for basically largely out of Dr. McSwain's estate through Mary's benevolence, and the donations of others. So if you like what you see, you'd like this to continue, whether you're able to give $1, a nickel, or 1,000, whatever you can. We use all this stuff to bring these things back to you, and we appreciate your support.